Dr. Jack West. I'm the founder and president of GRACE, Global Resource for Advancing Cancer Education. I'm very happy to be joined today by two great friends and colleagues of mine who have a rather international perspective from places they've practiced and just the experiences they have. I'll have them introduce themselves. First, Dr. Jarushka Naidoo.
Hi there. Thanks for the kind invitation to participate, Jack. So my name is Jarushka Naidoo. I'm a thoracic medical oncologist at the Beaumont RCSI Cancer Center in Dublin in Ireland, and I'm very pleased to join you all today.
And that leaves me next. I'm Gilberto Lopes. I'm a medical oncologist at the Sylvester Comprehensive Cancer Center in Miami, Florida. In prior lives, I've practiced in Latin America and Southeast Asia.
And you're also the editor-in-chief of the JCO Global Oncology Journal.
Indeed, I am. And a board member for the Union International for Cancer Control.
Excellent. And I should also mention that I'm a thoracic medical oncologist working at the City of Hope Comprehensive Cancer Center in the Los Angeles area. So we'll be talking, just giving our own personal perspectives as well as the general judgment as we see it of the present and future in lung cancer, using some of the ASCO presentations from 2022 lung cancer sessions as a springboard. I'd like to start with this study that was in the poster discussion section by a friend of ours, Dr. Charu Agarwal, who is at Penn, the Penn Cancer Center. And this is a single center but pretty large study looking at the arguable role of liquid biopsy. So one of the tenets of what we do, at least in advanced non-small cell, is based on assessing molecular testing, looking for potential driver mutations in patients. And unfortunately, we see that in the US, even in 2022, and probably very likely in other parts of the world, we get less comprehensive testing than we would like to see. Something like half of the patients with advanced non-small cell have broad molecular testing for the full panel of what are currently targetable mutations, at least 8, 9, 10 of them or so, plus another many more that are kind of emerging as potentially relevant. And ideally, we want to get what's called next generation sequencing, quite a broad panel. And sometimes the limitation is a lack of available tissue. This particular evaluation looked retrospectively at patients at Penn over a 2-year period, 335, most of them treated at the academic center in Philadelphia, some in some of the surrounding affiliated community-based centers, and looking at patients with advanced disease and what proportion had complete comprehensive testing of everything that would have been recommended in the NCCN, National Comprehensive Cancer Network guidelines versus less complete. And sometimes that less complete was for just 1 or 2 rare things that were not tested. And they also looked at whether the results were back when patients started treatment, because one of the other tenets of what we do now is we really want to have these tests completed before we commit someone to starting first-line treatment, sometimes because we have to change things once we get those results, and it's rather inelegant and sometimes a little risk-filled to start them on, say, immunotherapy with chemo and then need to switch midway. So this study looked at outcomes, and this is a lot of charts. It's rather complex, but as a general principle, this is called a Kaplan-Meier curve. And what it means is when you see gaps between 2 curves, it means that one group is doing better than the other. OS is overall survival. And what it's showing is on one side that the patients who had more comprehensive testing had better outcomes, lived longer, did better. And that was also particularly true whether they had complete or less complete testing and whether they had tests back by the start of treatment. And this was more likely to occur if patients had liquid biopsies, blood-based testing, in addition to tissue testing. And one of the challenges with tissue testing, and one of the reasons why we don't have 90 or 100% of patients with these results back, is oftentimes the biopsies are just a scant, small amount of tissue, and it's not enough to do the test. Another challenge is that the tissue-based test in particular can take weeks to get the full results back. And sometimes the physician is impatient. Sometimes the patient is impatient to get started. Sometimes you need to, because a patient is getting sicker by the week, but that's not common. So this is just one result at one center. And an implication of this, and certainly the practice at University of Pennsylvania, is really to do testing of blood and tissue upfront in just about everybody. And that is not a standard of care today. It has cost implications because you're sending for two platforms, two tests that cost a few $1,000s each. On the one hand, you are more likely to get your results back in a timely way. And in fact, the liquid biopsy or blood-based test tends to come back in 5, 6, 7 days instead of 3 or 4 weeks. But it's a question of, should we be doing what is potentially duplicative, redundant, and more expensive testing to have these results back earlier? I'd like to start, if I can, with you, Gilberto, just speaking to a global perspective on this. You travel a lot and see how it's done or not done in various settings. And I'd like your thoughts on this and what you think it should mean in the US, in various other parts of the world, especially since when I talk with folks in other parts of the world, I think in many places, the availability of tissue is woefully low. It's really distressingly low. And so is blood-based testing especially necessary in some other parts of the world?
And that's a great discussion, because it's not just about making the diagnosis and finding the target. It's also about having availability of the medications that we would be able to use to treat people living with cancer, lung cancer, that have those specific alterations. So it's a little bit even worse than what you might imagine. At our institution in Miami, we do both at the same time. We tend to do liquid biopsy, the blood-based testing, at the same time as we send tissue for the next generation sequencing. As you mentioned, this is not the standard of care, but we do it because we get the liquid biopsy a lot faster. And truth be told, there are some instances in which we do find targets that we don't find by tissue. That's usually not the case. It's usually the other way around. The sensitivity for the tissue-based testing is higher. But as you mentioned, there's a number of situations in which we don't have enough tissue, in which the samples were small. And I'm old enough to remember that at some point 20 years ago, we only got diagnosis of non-small cell lung cancer, not otherwise specified. We didn't check for the subtypes of the non-small cell lung cancer that we check today as adenocarcinomas and squamous, and I don't want to go into much detail. But as soon as we have medications and we have options for people for whom we find these targets, we do need to be looking for them. When we look at the situation in middle-income countries in particular, we do see that in some, you have some basic testing done. So let me use my home country of Brazil. For the 25% of Brazilians that have private health insurance, it is a standard to test for at least EGFR, ALK, and ROS1, especially because there are medications that are covered in the private system. But when you look at the public system, often institutions will not even test on purpose because they don't have access to those medications that you would need to offer if you do find a positive test. So it can be that difficult to practice in a lower income setting. And of course, we already have difficulties in the US, as you mentioned, in many surveys, up to 60% of practices, sometimes you don't get all of the targets that we would like to see. So this is a situation that needs to improve. In the US, having Medicare cover genomic testing has been extremely important, and that has led most private insurance to check. But we currently don't necessarily have coverage for both liquid and tissue, especially when done at the same time. So there's things that we need to do to improve the situation even here in the US.
Jarushka, can you talk about your perspective? You've practiced in a few settings, and I'd like your sense of how far to interpret these data. What do you do, and what do you think is appropriate to issue as what should be a standard of care in various healthcare systems as a policy?
Yeah, I think that it really is a tricky balance. So as Gilberto said in a previous life, not that long ago, I worked at Hopkins, and certainly our approach, I think, was similar to Gilberto's and yours, Jack, in terms of doing tandem tissue and liquid testing with, knowing that we'll get the liquid sooner and that we could action on a result based on that and then default to the tissue. So similar to what Gilberto outlined there, in Ireland, we do have access to the liquid biopsy, but not as a standard in every newly diagnosed case. So we have tissue for everybody, and we do have a panel that includes any molecular target for which we have access to a drug or a drug available on clinical trial. So that pretty much allows us to have access to virtually anything to be annotated. And liquid we can request if we feel that this is an unusual circumstance, maybe female Asian never smoker, where we want to do a broader panel. And I think that links back to not just access to the testing, but also the critical mass of molecular pathologists. So, speaking to the fact that, as we know, oncology is becoming more and more complex. We know as the years go forward that there will be an increasing need for medical oncologists. I think sometimes we forget the ancillary and team-based science that has developed around oncology means all of us need to grow as a specialty, and having access to people with molecular oncology training who can actually respond to this expansion of the number of liquid biopsies in a public health system that will need to be assessed, I think is a critical piece to allowing this to be implemented in a real life setting. And then I think when you look at different places across Europe, certainly the Swiss, I think very similar to a US model, but other places in Europe, certainly parts of Eastern Europe, maybe more similar to other countries where there's a greater disparity in testing. I think in terms of policy, this is what makes things a little bit difficult. I'm certainly a big proponent of liquid biopsy, and for the reasons that you highlighted, Jack, is I think in real life, again, real world data, the proportion of patients who require repeat biopsy for tissue is more often than we would think. We looked in our institution and it ranges from 20 to 30%. And when you think about that, in real life, that means sometimes a turnaround time of about 6 weeks. And certainly that is a critical time period for a patient to wait to get to treatment. So for that reason, I feel that is, an important endpoint that is of clinical meaning to patients. And in my view, would be a very strong reason for advocating for the liquid biopsy for all.
Yeah, I think that, you raised the point. I'm not as sure that we need to have we need to do the duplex testing for everybody out of the gate, but I think that we should have a very low threshold. If you don't have the tissue, jump right on that, because you raised the point, it takes 3 or 4 weeks, even if you get the biopsy tomorrow, but you don't get the biopsy tomorrow. You usually take 7, 10, 15 days to actually get that done and sent out. And then you add several weeks to that, compared to being able to get the blood drawn in your office that day reliably and send it out, by express shipping, and get the results back essentially in a week. So,
or at home, even now in these days where we do more telemedicines than we used to in the past.
Yeah, very good. That's true.